Evet.
Yes. In our daily practice, when I have a look at my prescriptions for schizophrenia patients, what attracts my attention is the use of more number of antipsychotic medications. In the past, I checked the prescriptions by others, and compared to the past, we use several antipsychotics together. Clinically, are we doing any benefit to the patient? This has to be something worth investigating, and in fact we are creating a risk in terms of side effects for the patient. And this is a study that I would like to present you, and this study emphasizes the same problem. Compared to 10 years ago, psychiatrists for schizophrenia patients tend to prescribe more antipsychotics. Why? One of the reasons why is that compared to the past, we feel ourselves more helpless, and in order to prevent this helplessness, we try using different medications in an effort to make the disease better. Possibly there might be other reasons, and one of such reasons, I guess, are the changes in the treatment targets, especially during recent years. Nowadays, for example, in the past we were dealing with positive symptoms. However, these days we are concentrating on the participation in life and the patient being able to work. So, work and getting better, what are these related to? This is a study on second generation of antipsychotics, and it coincides with the time when these were marketed. I do not know whether we will be finding a similar result if we were to conduct study today. This is a 5-year follow-up study. The important point is that it focuses on the improvement of symptoms and then the social and occupational functioning of the patients. As a result of 5-year follow-up, what was found, the number of patients who had improved symptoms is around 50%, and patients having significant social functioning around 40%, and patients who fulfill both criteria are around 15%. And in the study in 2004, at least 14% of the patients are having a full recovery. One of the reasons why I am presenting this patient is the factors predicting improvement are as follows. The time of psychosis, so if the number of psychoses are small, then they will have a better course in future. The level of cognitive functioning. The level of cognitive functioning initially foresees or predicts the cognitive functioning later in life. This is a study conducted by our group, and the relationship between quality of life and executive functions. Quality of life is something that is affected by several factors like negative symptoms, positive symptoms, and the relationships of the patient with others. And cognitive functions and their deteriorations are directly linked with the quality of life deterioration. And several studies focus on cognitive function abnormalities, and first-degree relatives of the patients usually have such problems. This is a meta-analysis, and we see that cognitive deficits are also present in relatives of patients, and they are similar to those found in the patients themselves. And one of the topics that is discussed very frequently are the secondary results, especially about cognitive function. Pharmaceutical companies are influencing the scientific data data, new medications are focusing on cognitive functioning and negative symptoms, and there is a data that is accumulating in that regard. However, when compared with perfenazine and other medications, we see that perfenazine seems to be better in cognitive functioning, and when we do not include tardive dyskinesia into the group, in new generation of drugs, patients with tardive dyskinesia were also included. We see that perfenazine was significantly effective. So first generation of drugs, second generation of drugs, dopamine antagonists, serotonin dopamine antagonists, and as concerns the effects on cognitive functioning and negative symptoms, we cannot see much differences. And once the confusing effect of EPS is eliminated, that discussion is no longer valid. So cognitive function and negative symptoms are the topics we have to focus these days. Here we see the negative symptoms, positive symptoms, depression, and neuropsychological functioning of the patient. So there is a relationship between work skills and those 4 parameters, and this was investigated. If you pay attention, these are directly correlated with each other, and positive symptom and depression are correlated with each other. Positive symptoms and depression has impact on work skills. However, this is of lesser degree compared to the effects of neuropsychological functioning and negative symptoms. So, for now, if we aim for an improvement in the patients in the area we aim at improving, we need to focus on new targets or new clusters, and this is a definition of such clusters. There are certain or several cognitive functions, and how do these have impacts on the work skills of the patient? First of all, visual memory is related to living independently. Attention is related to behavioral problems like treatment adherence and impulsive behaviors. Executive functions are related to social functioning. These have all been demonstrated, and this research is important, especially for different cognitive functions and their implications on work skills. When an evaluation is made, especially at the beginning, in the first 13 weeks, attention is of utmost importance. In the following period, however, verbal memory is important. Attention is important for recruitment purposes and employment purposes. However, the deterioration or problems in verbal memory are influential in their sustainability at the workplace. Another research by another group with the WCST test, we see the whole day work, and if the patients have a good performance in this test, they can work full day. They have a partial success, then they can use work part-time. If they are not successful in the test, then it is not possible for them to be employed. Wisconsin cards matching test shows us the basic dimension of the executive functions. Another question. In fact, there are several cognitive functions that have been impaired. Are these characteristics to schizophrenia, like executive functions? In the meeting during noon, there were data presented on executive function, which are specific for schizophrenia. The impairments in social cognition are more schizophrenia specific, and treatment targets should be evaluated accordingly, it was said. And social functioning or social cognition has several subgroups because for treatment targets, this has to be dealt dealt with. What are the new treatment targets in schizophrenia? We definitely need new ones, and related with new treatments, we need new treatment targets. Negative symptoms, cognitive functioning, quality of life, and psychosocial functioning are the main concepts that are in front of us when we are developing a new drug. Which of these concepts is the most appropriate and the most workable? If we are to look at cognitive function, and there are studies analyzing cognitive functions in a longitudinal manner, however, these are limited in size and yield contradicting results. However, when we talk about cognitive impairments in time, we see that this appears in schizophrenia patients, and as the disease progresses, there is an increase in the cognitive impairment, and especially during the first years of the disease, this is significant. Especially in patients who have psychosis, this cognitive impairment is even more. And cognitive impairment, is it an appropriate target for treatment? There are problems in defining this, and the most important point is that there are several cognitive functions that are impaired. Which of these should be used in an attempt to measure the cognitive impairment, or which tests should be used in an attempt to identify the disease? FDA, for an existing drug, in order for it to show a healing effect, there are test batteries. However, we have not seen any approval of medication being obtained after using these tests. Drug research then shifted from cognitive function to negative symptoms. Negative symptoms, and studying these symptoms is not that easy. In 2012, in a meeting by SIRS, there were participants from the academia and the pharmaceutical companies. The criteria were brought forward. So which scale should be brought forward, especially for the drug research on negative symptoms? And if we are to list these, first of all, age of below 65 years was included, and without comorbid depression. Depression can easily interfere with cognitive dysfunctioning, and the treatment targets can be mixed, and negative symptoms and functioning is evaluated together in some research studies. However, the priority should be on negative symptoms. When doing measurements, when evaluating negative symptoms, not only the information provided by the patient, but also those provided by the relatives of the patient should be taken into consideration. Regarding the negative symptoms, the most important point is the time, because for positive symptoms, within the first 4 weeks we can have a response, and for some it is possible to have a response in the first 24 hours, but for negative symptoms we need longer time. For phase 3 there were 12 weeks allocated, and for phase 3 26 weeks. In order to successfully define negative symptoms, the patients have to be stable, and they need to have received medications for 4 to 6 months. For patients who have predominantly negative symptoms, should these be included in the study or the others? There is no consensus yet. When we are to look at negative symptoms, and in the morning session these were dealt with, two important areas attract our attention. One is evolution and apathy, and the second is diminishment of the emotional expression and affective blunting and allogia. From this perspective, if there is affective blunting and allogia, these are related with the difficulties in the clinical practice. So, among the targets in the drug research, we have negative symptoms, and we will be possibly focusing on the subsets of negative symptoms in the future. So, when we have a look from this perspective, what type of medications do we have in hand? We have asenapine, iloperidone, and lurasidone abroad. Because of the practices of Ministry of Health lately, we cannot use these medications. Luraperidone and asenapine have different receptor profiles concerning negative symptoms. Lurasidone, 5-HT7 receptors affected. Asenapine, the 6 receptor is affected. And from this perspective, we see that different receptors might be helping us differently. The first one among these are the nicotinic alpha-7 receptor agonists, NMDA agonists, D1 and D4 agonists, mGlu-R23 agonists. In the glutamatergic system, we were anticipating a medication that would control negative symptoms from these receptors. However, latest research proved negative because glutamate receptors are the main controlling point for the brain, and in high doses and low doses it might have different effects. This was a psychotic model in animals, and when it was used in animal studies, when given at low doses, it can show positive effects, and when at high dose, it can create negative symptoms related with schizophrenia, maybe during the acute phase, when the glutamatergic system is very acute. In the chronic period, this might show decreases, which is related to negative symptoms. Maybe when we are using antipsychotic medications in the patients, we might be negatively affecting the glutamatergic system of the patients. From this perspective, there might be 2 medications that are important in the list. One is bitopertin, which is a glycine reuptake inhibition. When added to other medications, it can improve negative symptoms, which has been shown. And bitopertin is activating the glutamatergic system. This is a phase 3 study, especially at doses of 10 to 30 milligrams, when compared to placebo, had significant improvement of negative symptoms, and for psychosocial functioning of the patient, it resulted in an increase that was shown. However, the future research did not support these positive findings, and bitopertin was recalled because of negative effects. And there is another medication affecting the glutamatergic system, and it was shown to be superior to placebo together with olanzapine, and it didn't have any weight gain effect. However, in the second study, in the phase 2, the results were negative, and both of these medications are not in the market, and glutamatergic system does not have any medication that can be influencing the negative symptoms. This is an area that is worked very diligently, and there are studies performed on smokers, especially on phase 2 and 3. There will be a focus on nicotinic receptors and development of drugs accordingly, and we might be showing these drugs in the near future. Another thing, especially based on the schizophrenic inflammation hypotheses, there might be medications influencing the inflammation and results in the genesis of the neural cells. For example, regarding aspirin, there are several positive effects. Maybe drugs in this field might be of influence. This is my last slide. This is a review, in fact, and these are the medications at the stage stage of clinical research, you see which phases they are at and which mechanisms they are related to, and the companies in charge of these research processes, and especially alpha-7 nicotinic receptor is affected by many of these medications. At the universities, there are similar research studies, and one of the striking points is that antidepressants might be having positive effects on cognitive functioning and negative symptoms. So we definitely need new medications in order to control cognitive functioning and negative effects, and these might be added to the already existing medications through glutamatergic system and nicotine receptors. Thank you very much for your attention.